Multiple myeloma in the community will be our next session. I want you to get ready for an inspiring session. This doctor is a remarkable human being and has remarkable insight. Dr. Amani Kariokus, specialist in blood diseases, tackling multiple myeloma with groundbreaking immunology and oncology approaches. We want to extend a very special thank you to our platinum sponsor, Bristol Myers Squibb, for sponsoring this session. Let's give it up, Dr. Amani.
Good morning, everybody. Thank you for having me today. We'll get started in a little bit about multiple myeloma in the community. Today, we will cover several topics. First of them is a little explanation about what is blood cancers, fast facts about multiple myeloma signs and symptoms, and what exactly you need to diagnose myeloma. We'll talk about race and myeloma and using science in the treatment of myeloma, what is new in the world of multiple myeloma, and last but not least, could I have myeloma and what to do about it, and a little bit of a summary at the end. So what is the hematologic or blood cancers? First, is it a bone cancer? Really not. Bone cancer is a very rare type of cancer. It's called sarcoma. It presents like this, huge mass on the bone. Is it a cancer that has gone to the bones? Also not. These cancers are usually come in an organ like breast, colon, or liver, and then they go somewhere else. They metastasize into the bones, and that's a stage 4 cancer, but it's not the myeloma or not the blood cancers. Is it cancer of the blood cells that's produced by the marrow inside the bone? That is true. So in our bones lies the bone marrow. Bone marrow, talk a little bit about anatomy here. Bone marrow is the factory that makes up all of your blood cells. Majority of the cells in the bone marrow are the bone marrow stem cells. And these stem cells, they produce several types of cells. First is the red blood cells. These are the cells that carries your hemoglobin, deliver it to your organs, and give oxygen to your organs so you can live and function. White blood cells, these are the cells that fight infection for you. And the platelets is the glue in your blood that prevents you from bleeding when you cut yourself or when you have a surgery. There is also lymph cells. These lymph cells live in the lymph glands, and these fight foreign body for you. And the last is the plasma cells. Plasma cells are the cells that produce your antibodies. Antibodies, they are structures that fight foreign bodies for you. They fight bacteria, and they fight anything that is your body is not used to. When the stem cells goes crazy, that causes leukemia, a type of blood cancer. When the lymph cells goes crazy, that causes lymphoma, another type of blood cancer. And then when the plasma cells goes crazy and becomes cancerous plasma cells, that's what causes multiple myeloma. Start secrete crazy antibodies, we call it monoclonal or M proteins. And that can cause other issues we're going to talk about in a little bit. These antibodies are actually two parts. One is the heavy chain, the bigger part, and at the end, so the Y-shaped, that's the heavy chain, bigger pieces. And at the end, on the edges, are the light chains. We call it free light chains. And these antibodies is what caused the damage from the multiple myeloma that we will talk in a little bit about. They start secreting a lot of heavy chains, a lot of light chains. Multiple myeloma is a cancer of the bone marrow that comes from the plasma cells. As you see here, the bone, inside of it is the bone marrow and the normal plasma cells. All of us have normal plasma cells that secretes normal antibodies that fight infections for you. If it became cancer cells mutated, they go crazy. They start becoming a lot more of it, a lot of cancer plasma cells, and these cancer plasma cells start to secrete cancer proteins. And that's what is the multiple myeloma all about, monoclonal proteins, M proteins. So in the blood, myeloma is a cancer of the blood. It crowds out the normal cells in your bone marrow, and that's why your bone marrow, the factory, is kind of damaged from the inside, cannot produce what it needs to produce to help you. So that's how it presents with low blood counts, low white cell count, and mainly low red cells, anemia, and low hemoglobin. It's inside of the bones. So when these crazy plasma cells start to produce a lot of it, start to proliferate quickly, they start to damage the bone around it. And that will cause damaged bones. We call it lytic bone lesions. And when the bones are destructed, that's what releases the calcium from the bones into your blood. And these calcium first damage your kidneys. Secondly, because of this cancer protein, the monoclonal protein, or M protein, that gets excreted in your kidneys, damage the kidneys, and patients ends up with kidney failure or renal damage. So remember, CRAB, calcium, very high, kidney, which is renal failure, anemia, and bone destruction. Multiple myeloma is the second most common blood cancer. Around 35,000 estimated new cases of myeloma in 2023. In the US, in the statistics from 2021, there is around 138,000 patients living with myeloma. It's very common. It's most frequently diagnosed in old patients around age of 65 to 74 years old. And of course, the incidence of myeloma in Black patient population is much higher than white. 14 in 100,000 Black versus only 6 in 100,000 white. The signs and symptoms of multiple myeloma. First, because the factory, the bone marrow, the factory that makes up your blood cells is damaged, you come with low blood counts, anemia, and around 60% of people, they present with anemia, which comes with weakness, fatigue, losing your energy, and also recurrent infections. Decreased kidney function, kidney failure, usually comes with generalized weakness. And the bone damage, it affects around 85% of people and leads to bone fractures with no reason, not a trauma, not mechanical, nothing. It's just all of a sudden you fracture your bone, and that's from the bone damage from multiple myeloma. And because of the bone turnovers, produce a lot of calcium into your blood, and that will cause hypercalcemia. It comes with other symptoms, especially losing appetite, losing weight, constipation, episodes of confusion, abdominal pain. But also around 10 to 20% of people of newly diagnosed myeloma patients, they don't have any symptoms. It's diagnosed by accident. Overall incidence is slightly higher in men, 8 per 100,000 versus women, 5.7 per 100,000. And if you look at the US myeloma population by ethnicity, you find that 65% are whites, 19 Black, and 10 Hispanic, and 5 Asian. If you look at the SEER database, you find that among myeloma patients, the incidence of myeloma is 11 per 100,000 among all Black, and all the other races is less than half of that, 5.8 in 100,000. Hispanic, 5.29, whites, 5.26, and Native American is 4.5, with Asian around 3.2. So we can actually notice that the Black people have more than twice the myeloma incidence of white. And that mirrors the incidence of MGUS. Blacks have the highest risk for having myeloma of any race, ethnic group in the world. What is MGUS? MGUS is really having a little bit of cancer cells in your bone marrow that secretes a little bit of cancer protein but doesn't cause any damage. No anemia, no kidney failure, no hypercalcemia, and no bone lesion. It's basically, we know the disease is there. We know that is something that it can progress into myeloma, but it's not causing any problem. We usually watch it with blood work every 3 months or 6 months. And MGUS is very common in African American. It's 3 times more in people of African descent. African American patients with MGUS, they usually have lower M protein levels, higher rates of free light chains, the tiny at the end, and it's usually younger in age. Talking about risk factors for myeloma, there is really no conclusive evidence for myeloma being an inherited disease. But it's because it's more common in African American, it actually runs in the family just because it's more common in this race. Closely related to someone with myeloma does increase the risk of MGUS. So if you have any relative who has multiple myeloma, go ask your doctor to be screened for MGUS. The racial difference in incidence cannot be explained by tobacco or alcohol use or any socioeconomic status. Obesity increased the risk of myeloma, and we know that ionized radiation is the most convincing risk factor for multiple myeloma. Myeloma is different in African American. Black patients generally present at a younger age, 4 years younger than Caucasian, and they have more aggressive disease, more anemia, higher calcium, more kidney failure, higher lactate dehydrogenase, which is a marker for disease progression. They have more common these chromosome 14 translocation, which is targetable with a drug. There's a drug to treat it. Blacks are less likely than whites to have high-risk mutations. So usually the myeloma disease risk in blacks is actually a better risk than Caucasian. Recent data shows that under equal opportunity treatment settings, the African American patients, they actually do better than Caucasian when they're treated properly. Myeloma is more common in African America, and there actually increased incidence of having kidney failure from myeloma, but if it's treated properly, they do better. Unfortunately, because of lack of resources for African American patients, the survival rates for African American, they have not kept pace like with Caucasian people, just due to lack of education, lack of knowledge, lack of resources. The median time in African American is usually longer than Caucasian, with lower transplant for these patients. We'll talk about transplant in a little bit, and they usually underrepresented in all clinical trials, with limited disease awareness in African American. So how do we treat myeloma? There are several groups of drugs that can attack multiple myeloma. And usually the treatment for multiple myeloma is by a combination of treatment. Treatment is really first induction, which is 4 months of treatment. Combinations, there are so many treatment options available. Then consolidation with a stem cell transplant, or we call it a bone marrow transplant, followed by maintenance, and people stay on maintenance for as long as they live and as long as they respond. It's a chronic disease. And if they relapse, there are so many other treatment options for myeloma. Now, what is bone marrow transplant? It's usually you start with giving injections to stimulate the bone marrow, to free out the stem cells to be into the peripheral blood. And then we put a special line and collect those cells, the stem cells, and save them and freeze them until we bring the patient back, give him high dose of chemotherapy that wipes out all of the bone marrow, all what's in it. And then the following day, we infuse those stem cells back in their bodies. So actually it regenerates the whole immune system again from scratch. What's new in myeloma? Several things. You have 2 types of cells that fight for you. They serve and protect you from any foreign exposures. B cells attack outside invaders, and the T cells attack cancer cells, mutated cells. CAR T immune therapy is actually cytotoxic T cells. These are your own cells. How it's done is, so we take your own T cells. T cells are the cells that kill cancer from the patient body, collect them, and then enhance it. Put a virus on it that creates a CAR gene. This CAR gene, when it's produced at the edge of the cell, it actually have a target on it. It's called BCMA. This BCMA target is exposed on all of your myeloma cells. So what happens is these CAR cells, they get attached to specifically myeloma cells because they have a receptor to touch this BCMA and hook into it, and then they start killing the cancer cells. Once we have the cells enhanced, improved, then we infuse it back into the patient body. BCMA is expressed on all of the myeloma cells, so it's actually only targets your myeloma cells. So that's how it does. The T cell, BCMA, the enhanced one, they kind of bind to the BCMA myeloma cells, and they start killing it and get rid of it. That's the newer thing in CAR T. There are 2 CAR Ts available and FDA approved. The other thing is bispecific T cell engagers, which is really specific antibodies that we give to the patient that have 2 arms. One of them is CD3 arm, binds to the good T cells in the patient body, and the other arm is BCMA arm or other targets that actually grabs on a myeloma cells. So how it works is these antibodies have 2 arms, 1 myeloma, 1 T cells, and let them fight together and kill the myeloma cells at the end. There are 3 drugs available that are bispecifics right now, actually maybe 4 even, because the field is evolving. So that's how it does. Bring a T cell, a killing cell from your own body, and hook it up to the myeloma cells and make it to actually kill it like this. So now there are several bispecifics available, and they're all effective. I'm not going to bother you with the data, but it's available. Know that they're available and ask about them if you have a relative who has myeloma. Advanced in survival for myeloma. With new biology-based medication, 3 and 4 drug regimen is the best response rate. If you give a patient 3 drugs or 4 drugs, you can achieve around 98% of a response. There are even more than 32 drugs that are FDA approved for myeloma. With novel therapies are used, that diagnosis survival has significantly improved. Now we see the 10-year survival has significantly got better than what it was 20 years ago. Now myeloma patient can live for a decade or more. They can live for 10 to 14 years. People in the United States living or in remission from myeloma, it has gotten much better. In 2004, it was only 50,000 patients. 2011, it's 74,000. 2020, it's 144,000. And this year, we have 162,000 people actually living either in remission or getting treated for multiple myeloma. It's not curable. You can never get rid of it. Patient has to continue to be on treatment for the rest of their life, but is manageable, survivable. Even the treatment is very well tolerable. So could I have myeloma? Think back. Do you have any bone lesions, any bone pain, any anemia, weakness, low red cell count, any high calcium levels that you have ever been told about, or any poor kidney function? Has anybody told you that you have a poor kidney function? If you have any of these symptoms or any of these numbers, then ask for myeloma blood testing. Ask your physician to order myeloma blood testing. It's a standard of care anywhere in the world. Serum protein electrophoresis, free light chain assay, kappa and lambda, and immune fixation. You don't need to remember any of it. Just tell your doctor, I need to be checked for multiple myeloma. That's all. Now, because kidney failure is the worst prognostic factor for myeloma patients, there are several clinical trials that actually give 4-drug regimen. This one is giving 4 drugs for patients who has multiple myeloma with kidney failure. There is another cooperative group study that I'm leading, and it's also randomizing the patient to several treatments. And these 2 studies actually have a goal of enrolling African American patients specifically. It's because this disease in African American people is common, and the prognosis is poor if they're not treated properly. Now to conclude, myeloma has twice the incidence in blacks than all other races. The higher incidence of myeloma is due to higher prevalence of the precursor disease called MGUS. It's not a bad idea to actually get checked for MGUS regardless, because it's very common in African American people. Signs and symptoms of myeloma mimic many other conditions. So always think back: bone, anemia, calcium, kidney. And ask for myeloma blood test. Blacks have equal to even better myeloma survivals when treated properly with equal access to care. There have been remarkable improvements in myeloma research and treatment, and myeloma will continue to improve, and I would encourage everybody, if you know anyone with myeloma, ask them to ask about clinical trials, ask them to ask about CAR T and bispecific, because these are the newer treatment and they're very effective. That concludes my talk. I'm open for any questions.
Thank you for that helpful information that you have given us. If I can recall, you said that normally it's at stage 4. Is that correct?
It's not actually stage 4 cancer. It's just because it originates from the bone. That's why you think that it's a stage 4, but it's not. The stages in myeloma is only 3 stages. It's either 1, 2, and 3. 3 is the worst, but even with stage 3, the treatments are very promising as well.
Okay. How often do African Americans, what stages of the statistics show that they normally find what they are? Because it's discerning that a lot of people, myself, don't know much about it, and the information, again, was very helpful.
Absolutely. Yeah, as I mentioned, it's very common in African American. That's why, if you have a primary care physician, you have any remote symptom that you're concerned about, bone pain, anemia, elevated calcium, abdominal pain, constipation, anything like that, ask your doctor to order myeloma blood work for you.
Yes, I have a question over here.
Yes, sir.
I'm also a physician, a pain specialist, but I was curious to know how often is the presenting symptom bone pain or joint pain compared to the other presenting symptoms? Like, how often do you see that one?
How often they present with
Basically, the percentage where they have pain in the back versus how much of the time do they not have pain symptoms?
Well, around 80% of myeloma patients, they present with bone lesions. They actually get diagnosed when they go to the emergency room, complaining of back pain, and they find multiple lytic lesions. That's 80% of the presentation. That's how it looks like. Only 20% of myeloma patients, they don't have symptoms, but the others, they will come with symptoms majority of the time.
I have a question.
Yes.
Over here. How expensive is the treatment for this, and what percentage does insurance carriers provide?
Absolutely, great question. The treatments are extremely expensive, but it is all covered by your insurance. And even if it's not covered by your insurance, all of the drug companies, they actually have a financial assistance program. So I only treat myeloma. That's all of my clinic. And 80%, actually around 70 to 80% of my patients are African American. If you got diagnosed with myeloma, I have never had any problems giving the care that we need to our patients. And even if the drug is expensive for the patient, then we ask for financial assistance programs to help getting the right treatment to the patients. There is plenty of them. The Lymphoma Leukemia Society offers a lot of grants and help for African American patients specifically, because we know that a lot of the time they're resource poor. So your physician will work with you, and if the copay is high, there is always an alternative treatment that fits your financial situation.
I really enjoyed your presentation.
Thank you.
Now, how much does a role of natural herbs play into the new treatment that's coming up that will attack the growth of the cancer cells?
Well, there is no data about this. We don't know. That's the short answer. It's always better to have a healthy lifestyle, right? Natural herbs are always fine, but some of them, they can interact with the treatment. So I would be cautious with that a little bit. But always stick to a healthy lifestyle. That you will never go wrong with that. But unfortunately, we cannot tell if natural herbs help with any of the disease.
Thank you.
Thank you. Thank you very much. Thank you for having me today.